Hello everyone out there, my name is Peter and I thought I'd give a wee talk to teach myself and maybe teach you out there what is diabetes insipidus. The first thing I'd like to tell you is it is not anything to do with type 1 and type 2 diabetes, so forget that, put it on the shelf, learn it another day. Diabetes insipidus, to understand it, let's look at how normally things work. So when you get thirsty, it signals through various mechanisms like a drop in blood pressure and Ang2 from the kidneys themselves that you are thirsty, and this causes a hormone called ADH, antidiuretic hormone, to be released from the posterior pituitary gland in the pituitary gland. It is only one of two hormones released from the posterior pituitary gland, and this acts on the kidney. So this is the kidney, very crude drawing, and this is it in a microscopic form. This is the nephron, and you've got your glomerulus here, and your proximal convoluted tubule proximal to the glomerulus, and your distal convoluted tubule, and your lip of Henle. So that all works to concentrate the urine. And then you've got your collecting duct, and this is where ADH acts. So when you get thirsty, more ADH is produced, and this draws in water to the body so your blood pressure can be maintained, and you can go on living until you get water again. So ADH causes aquaporins to be produced in the collecting duct, which draw water back into the blood. This will inevitably concentrate the urine. So the urine will be higher in sodium and higher in urea if there's a lot of ADH produced in the collecting ducts. So, say you have a patient and you're working in hospital and they're drinking and peeing loads, and you're thinking, why is this person drinking and peeing loads? There are three possible scenarios to why they are drinking and peeing loads. Number one, they've just gone into a horrendous cycle of drinking, and inevitably they're passing out more water. They're on a night out, drinking a few beers, and they're passing more water to get rid of their fluid. Number two, their brain may not be producing this ADH hormone, and that is called cranial diabetes insipidus. Number three, their kidney isn't working, and the brain is producing this ADH hormone, but it's not being picked up by the kidneys in the collecting duct, and they are passing out more urine and drinking more dilute urine and drinking more. So how do you distinguish between these three groups of people? Well, the first thing you do is deprive them of water. It sounds very cruel, but that's the first test you do. And this will tell us who is just drinking loads and who has a physiological problem. So if you deprive them of water for a few hours and then take a urine test, the body's natural mechanism will kick in, and those who have primary polydipsia and are just in a cycle of drinking loads will be able to produce concentrated urine because their ADH is working. If you deprive them of water and they're still producing dilute urine, it is either a problem with ADH. It's a problem with them not producing enough ADH, or it is a problem with the kidney not being able to react to this ADH, so they will still be producing dilute urine. Okay, so that's the first test, and there you go. So if they are drinking loads in a cycle, they'll be able to produce concentrated urine after a short time. If they have a problem with ADH, they will still be producing diluted urine. So the water deprivation test, it's good if they are having psychogenic polydipsia. You just say to them, you're in a horrendous cycle of drinking loads, you need to stop and go to AA or something like that. Okay, Then you have these two groups of people left. It's either a cranial problem or a nephrogenic kidney problem. So this is when you do the short-synaptin test, and this is an injection of synthetic ADH. It's usually sometimes called desmopressin. If it is a problem with the brain and you introduce short-synaptin, if you introduce this synthetic ADH, the kidneys are working fine. So if you give the ADH after the test, we will be able to produce concentrated urine. Before the test, their urine's dilute. After the test, the kidneys are like, finally we have some ADH, we can produce concentrated urine, and that helps you diagnose cranial diabetes insipidus. Now, the causes of cranial diabetes insipidus are many, but just a few to highlight: sarcoidosis and other granulomatous diseases, Bryan tumours, which I've wrote down there, or brain tumours, and the main drugs you have to think about are phenytoin and naloxone. So that leaves you with the nephrogenic people, and when the brain is produced, when the short-synaptin test is given, it's not a problem because the brain is already producing this ADH, and the kidneys are still not working. So you will be, after the short-synaptin test, you'll still be producing dilute urine. So the brain's working fine. So it is a kidney issue, and the main ones for multiple choice questions I've found anyway, that the kidney is drugs. So the drugs you have to worry about that cause nephrogenic diabetes insipidus are lithium, and it can also be due to chronic kidney disease, which go and look up about them because I'm done. So hopefully this short video has helped you understand the concept of diabetes insipidus a bit more. All you nephrology professors out there, please be nice, because I'm just learning this for myself, and it is aimed at I guess, medical student level. So go off and research some of the things I've talked about, and thanks very much.